everyone, and welcome. If you're an emergency physician or a resuscitationist, you are in the right place. Today, we're bringing you an explainer focused on what is easily one of the most absolutely critical tools in your resusc BiPAP. We're going to take some pretty rigorous clinical guidelines and residency protocols and transform them into a really clear, actionable pathway for managing acute respiratory crises. We're covering the whole shebang, from the foundational physiology right down to dialing in those exact parameters on the ventilator when you have a crashing patient right in front of you.
Okay, let's dive into this. We're going to follow a high-yield clinical pathway to really master BiPAP today. We'll start with the core concept, figure out who actually needs it and who definitely doesn't, look at how to physically connect the patient, and then get into the really good stuff, setting the parameters and adjusting them on the fly. And of course, we'll wrap up with your absolute must-know takeaways and the references.
So let's kick things off with the foundational physiology behind non-invasive mechanical ventilation. Now, you might be wondering, what exactly is BiPAP in a physiological sense? It stands for biphasic positive airway pressure, and simply put, it's the application of two totally separate pressures, a baseline pressure and an inspiratory pressure delivered via a mask. The ultimate goal here? To augment your patient's tidal volume and clear out that carbon dioxide, all without having to pass an endotracheal tube. It's different from standard CPAP because it gives that extra push of pressure right during inspiration, actively assisting those failing, exhausted respiratory muscles. And this brilliantly illustrates the core of dialing in your settings. It all comes down to understanding the difference between IPAP and EPAP. Think of these as your two magic dials. IPAP, or inspiratory positive airway pressure, is your high number. It physically pushes air into the lungs, augments that tidal volume, and helps clear the CO2. So IPAP is your dial for ventilation. Conversely, EPAP, or expiratory positive airway pressure, is your low number. This keeps the airways splinted open at the very end of a breath. It recruits those collapsed alveoli and improves oxygenation. EPAP is your dial for oxygenation.
Moving right along to patient selection, because knowing who benefits from this support and who is actually put at risk by it is completely crucial.
According to the British Thoracic Society algorithm, non-invasive ventilation is a literal game changer for very specific disease states. The classic, absolute home run indication, a severe COPD exacerbation. Specifically, you're looking for patients presenting with a pH under 7.35 and a PaCO2 over 6.5 kilopascals, which translates to roughly 45 to 50 millimeters of mercury, especially if they are still tachypneic even after they've had an hour of optimal medical management.
But applying positive pressure blindly can be incredibly dangerous. We have to run through the contraindications. Absolute contraindications are non-negotiable: facial burns, fixed upper airway obstructions, and, most critically, an undrained pneumothorax. Trust me, you absolutely do not want to turn a simple pneumo into a lethal tension pneumothorax. Then you have your relative contraindications, which require a really serious clinical judgment call. We're talking profound acidosis with a pH dropping below 7.15, a depressed mental status with a GCS under 8, an actively vomiting patient with a huge aspiration risk, or honestly anyone who just needs an immediate definitive airway.
All right, so you've selected your patient. Let's transition to the physical equipment and talk about how we actually interface the machine with our crashing patient. Based on clinical guides like those from Vigan España, we have a very clear hierarchy of masks. The oronasal mask is your absolute, undisputed first-line go-to for acute respiratory failure in the emergency room. These acute patients are air hungry, right? They naturally breathe through their mouth to minimize nasal resistance, so this mask easily boasts the highest success rates. Now, if they start developing pressure sores on the bridge of their nose, swap to the total face mask as your second line. Helmets, they're fantastic for hypoxemic failure, like ARDS or pneumonia, because they let you use a much higher PEEP. But keep in mind, they are generally used for CPAP. And those little nasal masks or pillows, just keep them for chronic home care. They leak way too much during an actual acute crisis. Let's move to and see how this builds. We've got the equipment set up. Now let's talk about the actual ventilator settings. Once that mask is securely on, you're faced with a really critical question. How do we actually tailor these BiPAP settings to the specific underlying pathology? Well, you have to split your thinking right down the middle, based on whether you're managing a primary hypoxemia problem or a primary hypercarbia problem. The Maimonides Emergency Medicine Residency Protocol gives us some excellent practical starting points here. For hypoxemia, so think CHF or pneumonia, you want to start your IPAP at 10 centimeters of water and your EPAP at 5. Your primary focus here is on that EPAP, the PEEP. to prevent atelectasis and literally push oxygen into the blood. Versus hypercarbia, think your COPD or asthma patients, where you want to start your IPAP around 5 to 10, but keep your EPAP very low. Why? Because the gap between your IPAP and EPAP is exactly what drives the tidal volume. A larger pressure difference equals a larger breath, which allows the patient to blow off significantly more CO2.
All right, the machine is on, now what? Let's shift our focus to the bedside management and the dynamic titration you have to do during the resuscitation phase. Please don't just set it and forget it. Here are the exact algorithmic steps for titrating the machine. Step 1, you need to stand right there at the bedside and titrate the pressures by 2 to 3 centimeters of water every 5 to 10 minutes, all while closely watching the patient's work of breathing. Step 2, you absolutely must obtain a repeat arterial blood gas at 1 hour and then again at 4 hours. You simply cannot manage this blindly. Step 3, if that 1 hour ABG comes back and the pH remains under 7.25 or their respiratory rate is still aggressively high, say over 25, the non-invasive route is failing. At that point, you need to be preparing for immediate intubation or an urgent ICU referral. So the crucial point here, a massive clinical pearl to remember, is the number 20. When you're aggressively titrating that IPAP upward to get a larger tidal volume, you generally need to keep your maximum IPAP under 20 centimeters of water. And the reason for this is pure anatomy. Your patient's lower esophageal sphincter tone sits right around 23 to 25 centimeters of water. If your inspiratory pressure exceeds that tone, you are going to blow right past the sphincter, fill the patient's stomach with air, cause massive gastric distension, and drastically increase their risk of vomiting and aspiration. You've also got to watch like a hawk for warning signs that your therapy is failing. The NEMOSER guidelines actually detail several solid predictors of non-invasive ventilation failure. If your patient is over 40 years old, has a high severity of illness with a SAPS-2 score over 34, carries a diagnosis of ARDS or severe community-acquired pneumonia, or if their PO2 to FiO2 ratio remains heavily depressed at 146 or less after a full hour, well, invasive ventilation is highly likely. Clinically speaking, if you see decreased chest wall movement, it means they are tiring out, and you must intervene immediately. Okay, time to wrap up this explainer with some high-yield home messages and our source bibliography. Here are your absolute must-know home messages to arm yourself for your next shift. First, remember your 2 dials. Target IPAP to fix ventilation and clear CO2, and target EPAP to fix oxygenation. Second, grab that oronasal mask. It is your first-line interface for acute patients. Third, respect that 20 centimeters of water IPAP limit so you avoid filling the stomach with air. Fourth, force yourself to reevaluate with an objective ABG at the 1 hour mark. And lastly, have a very low threshold to proceed to intubation if that pH is still below 7.25, despite you maxing out the optimal settings. Now, if you want to dig a little deeper, the rigorous medical guidelines and residency protocols that formed the entire basis of this explainer are listed here. They span everything from the British Thoracic Society to clinical protocols from Maimonides Emergency Medicine and great European guidelines like NEMOSER. Now, what's really interesting to think about here is your next shift. The next time a crashing patient rolls through your doors in acute respiratory failure, exactly which interface and initial pressure settings are you going to reach for first? Take a second, rehearse the physiology, visualize the machine in your bay, and you'll be more than ready to take control of that airway. Thanks so much for tuning into this explainer and keep learning out there.